Hi, welcome everyone. Good morning, good afternoon. This is Youssef Cherif from the Columbia Global Center Tunis, and this is our second partnership with ICAP, and again, another hopefully successful partnership with ICAP. This time we're talking about COVID-19 in Eastern Mediterranean and North Africa. An update, we have a number of prominent experts on the region and public health here, and now I pass the floor to Dr. Wafaa El-Sadr to start the session. Thank you.
Thank you very much, Youssef, and welcome to all of you today for this very important webinar that we are very honored at ICAP at Columbia University to co-sponsor with the Columbia Global Center in Tunis. Today, we're going to have a focus on a very important topic, which is the COVID-19 epidemic in the Eastern Mediterranean and North Africa region. Unfortunately, there has been little attention paid globally to the dimension of this epidemic in this region, while at the same time we're aware that the data do indicate that COVID-19 has a substantial impact on the lives and the health of people in this particular region. So today, we are very honored to have three individuals, experts who are going to present, and I'll introduce them very briefly, and then we'll move on to our first presentation. So our first presenter will be Dr. Rana Hajjeh, and she is the Director of Program Management, WHO, for the EMRO region. She will be followed by Dr. Hechmi Louzir, who is the Director General of the Institut Pasteur in Tunis, in Tunisia. And then last but not least, Gerardo Noto will present, and he is the resident representative for UNDP in Libya. After the presentations, we will have time for questions and answers. I encourage you to please put those questions in the Q&A box as we move ahead, and we'll try to have the panelists answer as many of them as possible during our Q&A session. So without further ado, I'll hand it over to Dr. Hajjeh. Welcome.
Thank you very much. Thank you very much, Wafaa. Thank you very much, Cherif, for the invitation. It's my pleasure to be here. I will plan to cover briefly the epidemiology of the disease of the pandemic in the Eastern Mediterranean region, and also a quick update on certain characteristics of the regions and what we are doing in terms of the response to the COVID-19 pandemic. First slide, please. Next. So I'm sure in the interest of time, I'm going, sorry, I apologize in advance. I'm going to run some numbers and some graphs and epi curves relatively quickly. I think all of you have been following very closely the global status of the pandemic. And, you know, as you see here, globally, the world has hit more than 6 million cases and with more than 370,000 deaths. We are one of 6 WHO regions, and initially, similar to Africa, the epidemic was thought to be starting relatively slowly, except Iran, which was one of the main epicenters for the epidemic in our region. But lately, the numbers have been picking up very quickly. Next. So this slide is showing the progression of the pandemic in all 6 regions of the WHO. I just wanted to, for you to know that the y-axis, whether it's number of cases or number of deaths, while showing significant increases in most of the regions except EMRO, which hosts China, it's a different scale. So that the numbers are not exactly the same, even though the trends seem to be similar in most of the regions except EMRO. Next slide, please. And this is for our region, because I had to share the slides yesterday. These are the numbers as of June 1st. But I just noted actually today when I was reviewing that as of last night, we are reporting in the region a total of 546,237 cases and a total of 13,030 cases or death among these cases, which just in one day, we are seeing an increase of more than 17,000 new cases and more than almost 300 new deaths, just to give you an idea about the magnitude of the rapid expansion of the pandemic in our region. Next slide, please. Our region comprises 22 countries, and we cover almost all of North Africa except Algeria, which is part of the African Regional Office, and some countries that are not traditionally in the Middle East, but part of South Asia, including Pakistan and Afghanistan. And as you see, we have in our region, Iran continues to be the country with the largest number of cases, but we have many countries that are now getting also increasingly reporting more cases. I wanted to highlight though that just because we are seeing some countries, like especially many of our Gulf countries, reporting more cases, it all depends on the testing strategies in many of the countries. So we have countries like the Gulf countries who are now testing increasingly a large number of patients, not necessarily because they are sick or showing symptoms, while some other countries in our region, especially countries with limited capacity, like Somalia, for example, and Yemen, testing only patients who have severe disease. So this is why sometimes the regional overall picture may not clearly reflect the full epidemiology of disease. Next slide, please. And this is probably the slide that is the most helpful. So we follow very closely, all the countries in terms of number of new cases every day, number of deaths, and the case fatality ratio, which started being high initially in our region when we started. And as the epidemic progressed and improving case management as well as increased testing, our case fatality ratio now in the region overall is around 2 to 3%, to similar to what is reported globally. Although you see that, as I mentioned earlier, some of the countries are still showing high case fatality ratio, mainly as a reflection of their testing capacity limited to mostly severe cases. Next, please. And this one, just the main point I wanted to add here is that, again, to better understand the epidemiology, we need to be aware of all the changes happening either at the level of individual countries or at the level of the region. Here, for example, you see a small dip around the 25th of May, which coincided with the Eid holiday at the end of Ramadan, and where basically a lot of functions stopped. But also at the same time, this is despite the calls from countries to limit interaction and to enforce some of the social restrictions. This is an opportunity where people still get together, and this is leading now to increase the number of cases in the 10 days since Eid holiday ended. Next, please. These two slides, this one and the next one, I will just show quickly. And again, this is more to illustrate the different epidemiology in individual countries. We have various countries in the region that where the epidemic now is starting to really take off, including countries like Pakistan, Afghanistan. We are seeing a second wave in Iran. We have countries though like Jordan and Lebanon that have enforced significant restrictions and lockdowns that are starting to see the impact with decreasing number of cases. And we have some countries, as I mentioned earlier, the Gulf countries that are following a very aggressive strategy, testing strategy, but also testing, for example, all their migrant workers, because the epidemiology early on in these countries was characterized by some outbreaks among the migrant workers. So as a result, they have started testing all of the migrant workers in order to prevent further spread and to limit the impact of the pandemic. Next slide, please. Yes, and that's the points here. Maybe I want to point out to the map of the Saudi Arabia, KSA, which is the top right. They are showing the increase. Qatar, the same thing. UAE at the bottom. These are a lot of the cases being reported here are very mildly symptomatic or asymptomatic because they are testing all contacts. Next. So just in summary, few key points for the epidemiology. Overall, we have not seen a major explosive outbreak, again, outside Iran, as I mentioned, and this is something I can maybe address later in the questions and answers, why Iran. We have majority of our countries could be classified as countries that have local or community transmission, local meaning clusters of disease, and few countries that now have community-wide transmission. We do have 3 countries that have reported more than 20,000 cases, but again, as I mentioned, I wouldn't just stick to the numbers. We do have 1 country also, Iran, which is among the countries now considered the top 10 in terms of number of cases, and it accounts for almost half of our cases, about 45%. We need more data. Again, the limitation of what I'm presenting, it all depends on what countries report to us. Sometimes we have additional information at country level, and better to interpret data at country-specific data. We do have a few amplifying events in the region that I will talk about a bit more in the next few minutes, which is the religious events in many of our countries, the migrant workers, such as in the Gulf countries, hospitals and healthcare settings in Egypt, where we are seeing more disease, but still we do think we have a good window of opportunity to implement public health measures. Next. So quickly over this, I think many of you who are following probably WHO's activities know that shortly after the pandemic was announced as a public health emergency of epidemic of international concern, there was a strategic response plan that was published by WHO. And similarly, the region as well, we have our regional plan, the strategic preparedness and response plan. Next. And these plans have 9 response pillars. Again, in the interest of time, I won't cover them all. I will focus on few things that I thought would be of interest to the audience, but these include, as you see here, of course, the information system and epidemiology that I covered early on, all the technical areas, including case management, etc., points of entry, which was very important for this outbreaks due to importation of cases, knowledge management or science and research, plus logistics support, which was very critical for this outbreak. Next. And these are some of the major areas that the regional office in particular is supporting. We try not to duplicate efforts with a lot of the technical guidance that is issued by headquarters in Geneva, but we try to take them and adapt them to the context of the region. But we have also been focusing a lot, as you see in the slide in the picture on the top right, the importance of leadership and coordination at country level and incidents, what we call incidents management or emergency operations management, which is really a critical element of the response that needed strengthening in many of our countries. Next slide, please. So I'm conscious of the time, keeping an eye here. So these are a few things I wanted to highlight because I mentioned earlier that infections among healthcare workers and in hospitals is an important concern for us. And that's one the weak infection and prevention control programs in the region overall was one of the things we are emphasizing, and trying to be opportunistic, taking advantage of currently of the pandemic to ask countries to establish many of these programs at the national level, so there will be national guidance and coordination. Almost half of our countries, 10 out of 22, don't have a national program at the ministry level. Next, please. Wanted to, of course, I think you're all aware of why we are seeing more increase of cases among health workers. I mean, we've seen this not just in our region, but all over the world. There's a huge burden that our region in particular already had a shortage of healthcare worker, which was important to highlight. Next slide, please. And next, this table just quickly showing the number. We have countries like Egypt, for example, where infections among healthcare workers account for about 8% of the total cases reported, which is a big concern, and it's due to multiple factors that we can also discuss later. Next. This is again to just illustrate that the majority of cases among healthcare workers are among nurses, doctors, and lab staff. Next, please. And a quick word about our involvement in research. So our countries, many of them have signed up to the Solidarity trial for the large Solidarity trial for hydroxychloroquine and many of the other therapeutics. And we have, for example, one country, Iran, that is now, that has enrolled almost 1,000 patients and account about 1/3 of all patients enrolled so far in the Solidarity trial. And we see this as an opportunity to encourage more of our countries to engage in these clinical trials and contribute to the global knowledge. Next, please. Communications and community engagement is another area we have put a lot of focus on, mainly because we think there's a huge problem with trust, with the lack of information sharing, etc. And again, I think I would just invite you to probably go to our website to see the scope of activities that are happening. So next, please. I think I know it's my timer going off. I'm gonna just take 1 minute, if okay, Wafaa. This is again to highlight the massive operations taking on with supplies. We have a hub in Dubai that has been distributing lab supplies and PPEs to the whole world, not just to our region, but almost 102 countries have benefited from it. And despite all the major shipping and travel restrictions on flight, they have managed to do that. So this has been one of the success stories for our region. Next. Some special consideration, I think you're all aware that we have many countries with humanitarian emergencies. In the interest of time, I'll go through that quickly, just to highlight, because this is one of the factors that is impeding our ability to respond quickly. Many of these people live in very difficult situations, and they have weak systems to start with. Next slide, please. This is many of the refugee camps in our region. We account for about more than half of refugees all over the world. So this has been particularly a cause of concern, but fortunately so far we have seen very few cases of COVID-19 among the refugees in our countries. Next. The mass gathering, I have highlighted this before, but it's very important in particular for the Middle East and North Africa because of the importance of these religious events that can amplify the outbreak. And we have issued specific guidance both for Ramadan, for visitations to many of the shrines and the religious side that has, I think, helped also decreasing the spread of the pandemic in the region. And now we are in the process of discussing with the Saudi Arabia the issue of Hajjeh. Again, a decision should be made about that very soon. I think it's next, almost done. Lots of challenges, as I have mentioned, in terms of deficiencies in the epidata, the ability to test, the availability of PPE and various lab supplies, poor IPC, and also many countries in conflict with divided governments and a lot of politicization in the response that had made our job more difficult. But last not least, the fact that we don't have flights and international travel has limited our ability to provide hands-on support to countries the usual way we do it, with missions and technical experts traveling to countries to provide support. So a lot of this now is being done online. And I think the last two slides are probably okay. I don't need to go through them. Next, I mean, many additional challenges. Just wanted to highlight that in addition to the pandemic response, we are also focusing on ensuring that there is support to continuity of essential health services like immunization, maternal and child health, and others. And that's another area that we are trying also to provide support for countries, as we are already seeing the impact of the pandemic on decreasing coverage of many of these services. I think this is the one important question now, how to adjust the control measures. Many countries are looking into lifting the social restrictions, and WHO has issued some guidance, but we are providing a lot of direct support to countries to help them make these decisions, which is going to be our the main question for the next few weeks, until we have a definitive intervention like vaccine hopefully in place. Again, last slide, Faith, and again, thank you very much for the opportunity to present. Despite this being a major challenge for our region, we are hoping that some of the opportunities in terms of strengthening systems for response and preparedness will come out of this outbreaks and from all of our partners all over the world. Thank you very much for your attention. Last slide, please. Yeah.
Thank you very much. We really appreciate it, and the excellent foundation for our discussion. And please, as you think of questions, please type them in the Q&A box. We'll move next to Dr. Louzir. Please go ahead.
Okay, so I can start?
Yes, please. Go ahead, Dr. Louzir.
Okay, thank you very much. Thank you, Wafaa, for this opportunity. Thank you to Columbia University and the people here in Tunisia. Thanks, Rana, for the presentation on the whole region. So I will go to some specific aspects related to Tunisia. May I have the slide? First slide, please. In fact, now we think that we achieve it by slowing down the progression of the disease in Tunisia, at least for this time, for this moment now, and we avoid the overshooting of the health system. So we had very little, in fact, cases that need intensive care, health, etc. And the story started at March of this year, of course, and now we will see in the other slide what are the case number, which is now I have it here. It's 1,086 cases, and we performed 52,000 tests. I want to comment here that we use what is called the real-time PCR, which is the gold standard for the detection and the quantification of the virus. Now we start to use serological tests also. And the overall positive results is around 2%. That means, as you can see, that we use many tests for people who are with some symptoms, but also around people and contact person, etc. So the cumulative case in Tunisia is around 9.16 among 100,000 inhabitants. And the new registered cases recently, and we will have more detail in the next slide, please, are so the total cases, among the total cases, we have 284 imported. That means that cases came from outside Tunisia. in general, Tunisian who came to the country in general, and 800 cases at the transmission in Tunisia, in the country, for people who came from outside Tunisia. Now we have only one hospitalized patient in hospitals, only one. Around 89 people who are recovered from the disease. We deplore 48 fatal cases, and among the person healthcare workers, we have yes, a significant percentage, 13%, so 141 among the total cases that are patient individuals that are healthcare workers. Among them, 10 are imported, so 10 medical doctors, 10 came from outside Tunisia and developed the symptoms here, and the other are medical staff and healthcare workers that are working here. Next slide, please. So here you have the detail on the number of cases each day from the beginning of the epidemic to now, and the last information is on 2 June, so yesterday. And as you can see at the beginning, you have in red the local transmission, and in green the imported cases, and in red cumulative case. So as you can see, at the beginning we had many imported cases, and then in the same time local transmission. In the second phase we have mainly local cases because we stopped the planes, etc. But now, after at least 1 week of no registered cases in Tunisia, we have again some cases from imported cases from Tunisian origin people that came from outside Tunisia. And now I think the most critical aspects and the strategies should focus on how to manage the people and who came from outside Tunisia. And for this, there is a strategy that was developed by the Ministry of Health and the government in general to diagnose and to follow all these people. Next slide, please. So here you have another information on the incidence of active cases now. As you can see, in the majority of Tunisia, there is no cases in green, and we have between 0 and 3 cases in the Great Tunis. What we call Great Tunis is Tunis and Ariana and other cities around Tunis, but a few cases, and higher than 3 in southern part of Tunisia. These are the total cases now, not too much, and only 1 is in hospitals. The other are in specialized centers and with some healthcare system, etc. And in the other part of this slide, you have the reproductive rate, and now it's around 0.2, which is something important. Next, please. So I want now to comment, and I want to share some of the hypotheses on why Tunisia has been relatively spared by the disease. And this is the question that sometimes many people ask about it. So I want to say that Tunisia has, we have a good health system in the most developed in our region. Basic healthcare centers that cover the country, preventive medicine. We have invested in preventive medicine many years ago, good immunization program. People are vaccinated, and we have a good coverage in terms of expanded program of immunization. The question of climate We don't know. There is some studies that are trying to looking if there is some correlation between temperature and other factors, climatic factors, with the incidence of the disease. There is also a question about the circulation of other members of the coronavirus family. There is some important data that are recently produced and published in international journals, indicating that some immunity could be detected against some peptides that are common on some coronaviruses other than the COV-2 and the COV-2 virus. So it could play a role in some places probably, but this need some studies in order to show if there is a confirmation of some correlation between the presence of this kind of immunity in some people, and it could explain this relative resistance in some times. We have a relatively young population, and also the program that is developed by the Ministry of Health and Tunisian government with anticipation in relation to the management of this crisis, the mobilization experienced and disciplined team could also could be important, I think. And also I want to mention that the team who were involved in this program, it means the team of the different national reference laboratory for flu, but also respiratory viruses. The team of the observatory, the National Observatory of New and Emerging Disease, the team of what is called the Primary Healthcare Directorate that depends on the Ministry of Health and also for the observatory, and many other people were involved some years ago in a program that is supported by CDC Atlanta that is around flu, and when this epidemic arrived, the same team were involved in the riposte and in the diagnosis and the control and the management of coronavirus. And probably this experience with the preparation through this program that is supported by CDC helped these people to be, let's say, more efficient in the control and in their involvement and activities to combat the coronavirus and this COVID disease. And I think I finished. Thank you very much.
Thank you very much, Dr. Louzir, and thank you for the information about the response in Tunisia. Very, very interesting. And last, we'll move to the presentation by Gerardo Noto from UNDP in Libya. Please go ahead. Thank you.
Thank you. Thank you very much. Thank you for the invitation, the opportunity to Dr. Wafaa and Youssef and Columbia University to share the experiences that we are facing in Libya regarding the COVID-19 pandemic. First of all, as you know, Libya is a country in conflict. It's currently war in south of Tripoli, in some other areas in the west, and the whole fighting dynamics impacts the whole country in the east and particularly also in the south. And so the COVID-19 crisis comes on top of several crises. Of course, security, military crisis, political, economic, financial, and definitely also on the health sector, among others. It's a country that has been very unstable and in war for almost 10 years. And then, of course, presents a lot of gaps and weaknesses when it comes to face all these different crises and the impact that it has on people altogether. So on the limited time I will have, I'd like to share some the way the UN has developed and implemented an integrated approach, integrated response to the pandemic in a country in conflict like is the case in Libya. First of all, the UN has developed its response based on 3 pillars. Definitely, as it was shared by my colleague from WHO, the first response has been regarding WHO and all the support by the UN system to the health emergency. And there I will expand on some of the issues we've been doing in the case of Libya, similar to the situation in other countries. The second pillar is Libya is a country with humanitarian needs. There is around 1 million people with different kind of humanitarian needs. There are 400,000 IDPs, 200,000 generated because of the most recent war for the last 15 months. And therefore, the humanitarian response has continued, but again, it has to be upgraded to take care of additional vulnerabilities generated by the pandemic and by the response to the pandemic. And the third pillar in which UNDP plays a very important technical leading role is the socioeconomic response, which is, of course, is more from a development perspective, but it's also looking into the most immediate impact on the 12-18 months span. So basically the rest of this year and 2021. In the case of has this UN approach to the response has played out in the case of Libya. First of all, in terms of health emergency, of course, the leadership is under WHO, but all of us has been supported with different actions. In the case of UNDP, we have a very important what is called a stabilization program in Libya, as in other countries in the region, in which we support communities and the local and central government to reestablish conditions after the impact of conflict, to allow people to come back, to allow people to rebuild their lives. And those actions has been implemented in the case of Libya around the whole country, and not only in the west, but also in the east and the south. So there is that work a lot is also related to the response. We work on strengthening infrastructure on the health sector, and some of those action has been refocused on the needs for the immediate response regarding COVID-19, provide some strategic equipment, testing capacity, which is very low in the case of Libya, providing procuring not only equipment, but also the inputs to use that equipment, and in that collaboration not only with other UN agencies under the WHO, but also with the Ministry of Health and the central government in Tripoli, as well as try to support the capacity to generate locally and provide PPEs, among other issues. In the case of when it comes from the UNDP response, of course, the response to support the health emergency has been a priority, but also we are adding to more governance and development perspective. The second dimension I think is very important to look into these crisis countries is governance and government capacity to respond. And of course, when it's the case of the health system, it has been affected by such a long time of protracted conflict, the lack of response in terms of all the infrastructure, but also in terms of human resources, equipment, and capacity of medical personnel. And so all those things are particularly highlighted during this additional crisis on top of the overall health situation that we face in the country. But in terms of the governance, of course, first of all, we know there is one recognized government in the West, in Tripoli, but it's not controlling the whole territory. There is alternative governance arrangement in the East, and there is the situation also in the South, which is very dynamic in trying to respond to these two centers of governance influence. And so this is very difficult to coordinate a response. It's very difficult in this split governance situation to be effective. So there is a lot of effort in that regards, from a technical perspective, also from a governance perspective, but in particular, the capacity to respond to crisis management. This crisis and other crises that they are facing. So there is a lot of effort in that regard in terms of providing tools and capacity and strengthening the response right now. In terms of, and then what we have identified as And governance and crisis management has to do with this split governance, but also in terms of the capacity to coordinate by the central government, and particularly to coordinate with the local government in a different region, which is a very, very significant challenge. In terms of the socio-economic response, it's a UN integrated socio-economic response, looking into from a development perspective, but also from an emergency in the 12, 18-month span. And then, of course, the work is to identify additional vulnerabilities of people generated by the COVID-19 pandemic, and also additional groups like informal workers, how it has impacted on migrants, how it has impacted SMEs, how it has impacted in women, with a particular concern about, because of confinement, of not being able to reach out to services in support of women with an increase, like in other countries, of gender-based violence. Just to mention some of the additional challenges that presents to people, generated to people for the pandemic. In terms of socioeconomic response, we are looking into 5 what we call streams, of course, to look into the health system, additional capacity to not only manage the current crisis, but also to be able to be in better condition to face the impact of this crisis and additional demands in the health system. The social protection, working, of course, not only from the UN's perspective, also engaging the national and local actors. Additional needs in terms of social protection to groups and to people already on needs of support. And then, of course, economic recovery, how this has impact in terms of jobs, losing income, impact on SMEs, the confinement measures, the lockdowns, the curfews, and difficult access, on top of additional restricted situation because of security, because of the division. So all this has been and is being assessed, as well as the macroeconomic impact. Is the countries facing an economic crisis even much before the pandemic. The oil embargo that has been in place since early this year, shutting down all income to the country, or most of the income to the country, and impacting, of course, on the fiscal situation, which is quite critical because of the war, and of course because of this losing of the most important income coming from oil. And of course, the last stream, but not very important too, in terms of reconciliation, community, how that has impacted at the community level on minorities, on groups, and how the dynamics in communities has been even additionally challenged because of the pandemic. Also looking into issues about communications together with the agencies, the stigma generated with the impact with people that identify as having the disease. There is an initiative in terms of trying to reach that separation with what we call health diplomacy, trying to use engaging not only official actors, but non-official actors to try to identify possibility for coordination of the response, and also opening up a way for dialogue beyond the immediate crisis and the health area, as well as looking into ways to contribute to measures within the very restrictive fiscal space, looking into support to economic actors and job protection and generation. One final point is, even though when you look into numbers, Libya has shown less than 200 cases confirmed, that's because of several reasons. One, the testing capacity is very limited. It's very limited. In the last few weeks has been a certain peak, particularly in the south, where the migrant groups, or some of the migrant groups, go into the country. And so there is additional concern that because of the capacity is very weak, it's very important to strengthen the possibility to cope with the situation at the low numbers. Anyway, the current numbers, we assume they are much bigger because of the testing is very limited. On the other hand, also, it's important to see that Libya was already an isolated country before the pandemic. There were very few communication between Libyans and the outside world. And within, because of security constraint, there is also this social life in Libya is very limited. But still, there are a situation in which IDPs, refugees, migrants, with either on detention or not on detention, are facing very, very, very challenging situation, which has to be fragile in terms of their possibility to get the disease. With all this complexity, we're trying to respond. I think so far, particularly in the case of the health emergency,
maybe 1 minute, Dr.
Yes, I will wrap up.
Yes, thank you.
And so, as I say, the country has an immediate situation that needs to be responded, particularly on the health dimension, but there's also other dimensions, increasing the humanitarian needs and vulnerabilities, and looking into socioeconomic response that are also very important when it comes to support countries to really face the challenges presented by the pandemic. Thank you. Thank you very much.
Thank you very much, and thank you for providing a very important perspective in terms of a crisis country like Libya. So thanks to all the speakers, and thanks for all of you who have actually put in some questions into the Q&A box. Please keep doing so. I'll try to very quickly go through a few of the questions that I've seen, and encourage the speakers to answer as brief as possible so we can respond to as many of the questions as possible. So let's start with Dr. Rana, and one of the issues you mentioned very briefly. Can you tell us, you mentioned that you could go into a bit of detail as to why Iran was so severely impacted. What are your thoughts in terms of that issue?
Yes, thank you, Wafaa. Thank you for the question. I mean, this is it's an issue that we are still actually trying to fully understand. But what happened in Iran, and especially now in retrospect, we did have a mission actually able to go to support the country initially. And it looks like the early, even though the early cases were reported around right after mid-February, they think that probably the first case happened around maybe at least 3 weeks to a month before. So, at the time, because, people were not suspecting yet, the clinicians were not suspecting COVID heavily, we think that they, could have missed these initial cases, and especially when people were mostly relying on history of travel to China, where some of these people did not directly have history of travel to China. So Qom, just to give you an idea, Qom, which was the epicenter also in Iran, is a religious city, of course, and side, but also is a city that has a lot of trade with China, we learned, and also many people who come as religious scholars, they call them like resident scholars, who come to Iran as well from China, from some Muslim scholars. So we think it's a combination of factors, but probably there was quite a bit of transmission happening before the outbreak was identified and detected.
Great. Okay. And maybe just a follow-up question to you also is, the issue about hospitals and healthcare workers in Egypt and so on. Does that, and it looks like, of course, training on infection prevention control is very critical. Has there been any evidence of a decrease within hospital or kind of nosocomial transmission in Egypt over time? And is there a shift from that to more of community transmission that you're detecting?
Yes, of course. And even now, I think there has been a decline. What I reported was the overall numbers, but since the beginning of the outbreak, again, when, some exposure happened among healthcare workers to patients who were not initially suspected to have COVID that had led to more transmission, the actual case fatality or the proportion of healthcare workers of the total number of cases has also declined in Egypt, with more awareness and better use of PPE and other in hospital setting. But now, and there were maybe small outbreaks at the beginning, small clusters, but now the majority of the transmission is actually in the community. Mm-hmm. And why we had that initially in Egypt? Egypt was actually one of the first countries in our region to have a national infection control program at the ministry level. But again, you know, it's one of our largest countries. They have very crowded hospitals and the low ratio of you know, healthcare workers to patients. So they need also more staff in the hospitals.
Thank you. For you, Dr. Louzir, you know, there's several questions about, there's a really large variability in terms of the mortality or case fatality ratio or across the different countries. And can you just share with people why there would be such variability in mortality across different countries?
Yes. So in comparison to the other countries of the region.
Yes.
Okay. So probably one factor is the number of cases or diagnosed cases, because as I mentioned, we used relatively high levels, let's say, of tests in the people. Because we have only 2.1% of positive results. So that means that we tested many people, and we detected asymptomatic cases. As I told you that now we have only one hospitalized patient, but we still have, I think, some number of active cases. The number is I don't know. So 73.
Yes.
So this explains why probably the mortality percentage of mortality is not too high, but it's significant. It's around 4.4%, which is relatively high compared, for example, to Germany, where a large amount of tests has been performed in the population, the whole population. So it depends on the number of tests that we perform. But another factor is probably the less severity and the less the relative protection, let's say, of people, and we are looking for that because there is a big difference when we compare with other countries in the region, but also outside the region. So there is some intriguing question still in this disease.
Yeah, and some people have raised the issue is that, of course, attributing the death to COVID-19 means that you have to be able to test somebody so there probably are a lot of undocumented mortality that's happening that's COVID-related that's not counted as COVID-related. And this has been seen even in the US, for example, where when you look at the, you know, kind of the excess mortality in different parts of the United States and other countries, you'll see that COVID-19 certainly is a major part of these excess deaths, but there are other deaths that are likely COVID, but the individuals were just not tested for the disease.
I don't think that this happens in Tunisia because we have a very good system for case declaration and for people who want to call. We have a number, etc. And this is one point. And we know that especially at the end, so 1 month before, during May, there is very reduced number of people who ask to ask for help and health system, etc. So this is one point. Second, we analyzed the death proportion and people, etc. during this period, and we have a number that is inferior, less than during the same period for the last year.
That's interesting.
Yes,
unusual.
Yes, no, because we reduced the traffic, etc. There is less
Violence.
And yeah, exact. And the second point is in Tunisia, we know the cause of death, and if there is any doubt, we apply and we test the dead people for coronavirus, etc. So I don't think that this the death known causes could account for the COVID.
Yeah,
for Tunisia, at least.
Yeah, I think I was thinking more across other countries in the region. And in addition, another issue, of course, is the strength of the healthcare system itself, and having trained healthcare workers and having sufficient intensive care unit beds and ventilators and so on. Maybe because of the time, maybe one last question to Gerardo is, you know, you talked about stigma, and which is very important. And certainly in many countries around the world, there's now recognition that COVID-19 affects vulnerable groups of populations, usually the more likely, at least in many countries, to affect people who are poor, people who don't have access to resources, people who cannot socially distance, and people of racial, ethnic, and other minorities. And there's the stigma that's now perceived against COVID-19. So it's interesting that you highlighted this as something that is of importance. Maybe in the last minute or so, you can speculate on stigma, and not only in Libya, but beyond that. And what we can do about it.
Yeah, no, definitely. There is a lot. What we have in Libya and other countries is like the disease has been associated with certain groups, migrants, because it usually is coming. The early cases coming from people from abroad, but they also is affecting certain groups that is already suffering exclusion. So you these different levels of exclusions or limitation to access to services, being migrants or refugees or people, members of minorities or women. So this is very important, and the way we are working to that is engaging communities, developing awareness campaigns, and explaining. It's a very powerful message from the UN in general, and of course definitely also in the case of Libya, to educate, to explain that we should prevent the stigmatization of people affected by the disease, but explain how to prevent it, how to treat it, and of course in support of the people that has been affected. And so that's an effort that we continue to make, and we just these days are strengthening and launching a very nationwide campaign in that regard, engaging different UN agencies and local actors.
Well, thank you very much. I want to end by, of course, thanking our three excellent speakers who really highlighted some of the issues regarding COVID-19 in this region, as well as the challenges ahead, but also some of the successes that have been achieved under some rather unusual and sometimes very challenging circumstances. I want to also thank as well our partners in this webinar, the Columbia Global Center in Tunis, and all my colleagues at ICAP who helped organize this webinar. Thank you very much for your attention, and we invite you to join us on our next webinar, which will be next week. We have a webinar sponsored by ICAP and by TAG and the COVID working group here in New York City that will be focused on modeling of COVID and other infectious diseases. Please join us next week. Thank you very much and have a good day.